Hello and welcome to the second episode of Paediatric Emergencies. I'm Chris Flannigan and I'm a Paediatric Intensivist from the United Kingdom, and in this series I'm working my way through the common paediatric emergencies and trying to provide a structured approach to resuscitation and stabilisation of the critically ill child who needs intensive care support to be initiated outside the intensive care environment. So as I mentioned in the last episode, I'm releasing these episodes in both an audio and video format, along with an accompanying text file. So you can watch these as video presentations on YouTube, and my YouTube channel name is Paediatric Emergencies. So you'll find a link to that channel in the show notes, and if you subscribe there, you'll get notified automatically as and when I release a new episode. So I've also made the audio part of the talk available as a podcast. And again, the name of the podcast is Paediatric Emergencies. You can get the podcast from either iTunes or in any podcast browser. And again, just by searching Paediatric Emergencies. Although I'll put the links to the podcast feed into the description as well, both for iTunes and for non-iTunes podcast browsers. And again, I'd recommend that you subscribe there, so you get any new episodes as and when they're released. So as well as having a listen to the talk, it's also worth having a look at the accompanying text file, which again, the link to this will be in the description. And this is really the corresponding chapter from the guide I'm writing entitled Waiting for the Paediatric Retrieval Team. Okay, so let's get started with this episode. And here I'm going to cover one of the most common paediatric emergencies, Status Epilepticus. And like I did the last time, I'm going to start it off with a case. Okay, so the case is a 15-month-old girl who is brought into her local accident in the emergency department by ambulance, having a generalised tonic-clonic seizure. So she had been previously fit and well child with no significant past medical history of note, normal development, and all her vaccinations up to date. She doesn't take any regular medications and has no known drug allergies. The only family history of note is that both her father and older sister had febrile convulsions, but there's no family history of epilepsy. And there's no history of trauma, foreign travel, sick contacts, or possible toxin ingestion. She's been unwell for the last 48 hours with coryzal symptoms and pyrexia. And apart from being more lethargic than usual, she has no other systemic symptoms of note. So she was at home when she just spiked a temperature, for which her parents had administered some paracetamol and ibuprofen. And immediately following this, she started seizing. So an ambulance was called. So en route to the emergency department, the paramedics had given her one dose of rectal diazepam at 5 milligrams. So when she comes into the resuscitation area, you assess her using an ABCD approach. So her airway with a head tilt, chin lift is clear and patent. When you assess her breathing, she has a respiratory rate of 54 breaths per minute with mild respiratory distress. On auscultation, there's good air entry throughout her chest, and as you'd expect, lots of transmitted sounds from the upper airways. Peripheral oxygen saturations are 95% on the 15 litres of oxygen via non-rebreather bag that you've applied. Looking at her circulation, although she's cool peripherally with some peripheral modelling, she's warm centrally with a cap refill time of less than 2 seconds. Heart rate's 168 beats per minute, which is shown as a sinus tachycardia on the monitor, and her blood pressure a little high for her age at 108/66, but what you'd expect during a seizure. Looking at her disability, she's having a generalised tonic-clonic seizure. Her pupils are large, but react briskly and equally to light, and her blood sugar is 7.2 millimoles per litre. When you check her temperature, it's elevated at 40.2 degrees C. There's no evidence of any rash or trauma. So you go on to manage her as per the APLS guidelines. So as she has good veins, you insert a an intravenous cannula rapidly, send off some routine bloods, and give her 1 milligram of lorazepam, which is 0.1 milligrams per kilogram, using an estimated weight of 10 kilos. So 10 minutes following the lorazepam dose, she's still having ongoing seizure activity. So that's now 2 doses of benzodiazepines that she's had, the dose in the ambulance of rectal diazepam, and now 1 dose of intravenous lorazepam. So you plan to load her up with some phenytoin, at the dose of 20 milligrams per kilogram. So you give her 200 milligrams of phenytoin over 20 minutes. At the same time as hanging the phenytoin infusion, you ask for an anaesthetic review. As you have no obvious source for this temperature and can't exclude at this stage an encephalitis or a meningitis, you cite a second intravenous line and elect to treat her with 50 milligrams of cefotaxime and 500 milligrams per meter squared of acyclovir. So another 20 minutes have passed following the phenytoin loading dose, and it's just completed, but she's still having ongoing seizure activity, so a decision is made for an RSI. So this is a relatively common presentation that most emergency departments will be well used to managing, and although many children settle down and seizures terminate with the initial treatment that's given, there's still a fair number of children who go on to need intensive care support. So now I want to talk to you about how you should manage a child who does need an RSI and ongoing intensive care support. And like I did the last time, I'm going to do this using a systems-based approach, starting with the airway. So although many of the medications that we give during a prolonged seizure can depress the breathing, most of the time, as long as the airway is patent, the child will continue to breathe adequately and maintaining good oxygen levels. The most important thing is actually maintaining a clear airway. And the simple way to do this is airway opening manoeuvres, so things like a head tilt and a chin lift as used in this case. However, if the seizure is occurring following trauma, it would be important to note that a jaw thrust should be used in preference to a head tilt and chin lift. Likewise, in a patient who hasn't had an injury, if you're not managing to maintain the airway with a head tilt and chin lift, a jaw thrust can be added in addition. And while you're doing this, it's important that high flow oxygen is administered, and the best way to do that is with a face mask with a reservoir bag with 10 to 15 litres of oxygen going through it. And secretions will tend to build up during a seizure, and it's important that these are suctioned to maintain a patent airway. If you're not able to maintain the airway with the above measures, it's often useful to insert a nasopharyngeal airway. Again, providing there's no history of trauma, as a risk of basal skull fracture would be a contraindication. It's often not possible to insert a Goodell or oropharyngeal airway in a patient who's having a seizure, as the teeth are often clenched closed. So looking at the indications for intubation in a child with a prolonged seizure. So I think first and foremost, if you're not able to maintain a patent airway with all the above measures, regardless of where you are in the algorithm, you should proceed to secure and protect the airway with an endotracheal tube using an RSI. So during the seizure, the patient's level of consciousness is going to be depressed, and their Glasgow Coma scale is going to be less than 8. So they're not going to be able to protect their airway should they vomit. And in this scenario, it would be important that the airway would be secured to prevent aspiration. All the medications that are given for termination of the seizure have the potential to cause respiratory depression and, in fact, a respiratory arrest. So should this occur, the respirations should be supported with bag and mask, but this is really only a temporary measure, as you've got a patient with inadequate airway protective reflexes. They often have a stomach that's full of food and that is now being filled up with air as you're bagging the patient. So bag valve mask should really only be used while preparations for RSI are made for as short a period of time as possible. So probably the most common reason for intubating a child with a prolonged seizure is that the seizure itself doesn't terminate with standard treatment. So looking at the algorithm, an RSI is recommended if the seizure hasn't terminated with the completion of the phenytoin or phenobarbital infusion. And the reason for doing this is that should the seizure be allowed to continue, the child is at high risk of cerebral damage. So should the seizure itself terminate with treatment, there still may be a couple of reasons why you may want to intubate and secure this child's airway. If there's concerns about raised intracranial pressure, intubation and ventilation to allow CO2 control may be required. Or you may want to transfer the child for neuroimaging, and it may be decided that the safest way to do that is with a secure airway. So it would be good practice to inform the anaesthetist or intensivist whenever you're starting either phenytoin or phenobarbital, or if there's any airway concerns at any stage, you should obviously let them know sooner than this. And the reason for doing this is that preparation for an RSI takes time, and really you want to be in a position to administer the anaesthetic the moment the phenytoin infusion is complete, should the seizure be ongoing. As I've mentioned, the longer the seizure goes on, the higher the risk of cerebral damage in this child. So planning is really important with this. It's also important that whenever you're phoning your anaesthetist or intensivist, that you let them know the reason you're phoning them. You're not phoning them for an anaesthetic opinion on this child. And what I've seen in the past is sometimes a junior anaesthetist comes to the emergency department to perform an assessment, but they're not confident to administer an RSI and intubate a child without their senior being present, which then, if they're at home, the termination of the seizure is delayed. So it's important that you let them know on the phone that you would like an RSI performed in 20 minutes, should the seizure not terminate, so that they can get senior backup should they need it. So should RSI be required, the recommended drug to be used for induction is thiopentone due to its anti-epileptic properties. So the recommended dose is 4 milligrams per kilogram, or if you're a neonate, 2 milligrams per kilogram. However, all induction agents must be used with caution, and the dose should be adjusted according to response and the patient's hemodynamic status. So cardiovascularly unstable patients should be given much less than the doses stated here. So if you don't have thiopentone available, propofol would be a suitable alternative, again at a dose adjusted according to the patient's hemodynamics. So with most patients with simple febrile convulsions and good hemodynamics, I wouldn't routinely volume load them prior to induction of anaesthesia, but it would be important to have 10 to 20 mL per kilo of normal saline drawn up and prepared to administer should hemodynamic stability occur. As you're using thiopentone for induction, there's a risk of vasodilatation and hypotension with its administration. So I think it's good practice to have some vasoactive drugs prepared to treat hypotension should it occur. My personal preference is to use a little bit of push dose adrenaline, 1 in 100,000, and I again just reserve that should hypotension occur. So we come on to choice of muscle relaxant, and like most RSIs, you have a choice between succinylcholine and rocuronium in an RSI dose. So for prolonged seizures, I think succinylcholine has a number of potential advantages over rocuronium, provided it's not contraindicated, and it would be my preferred drug of choice in this scenario. So the dose of succinylcholine varies depending on age. Above a year, it's often 1 milligram per kilogram to 1.5 milligrams per kilogram. below a year, 2 milligrams per kilogram would be the normal dose. And the main reason for using it in status epilepticus is its short duration of action. So you would expect the effects of succinylcholine to worn off after about 5 minutes. And at that stage, you're going to be able to perform a good neurological exam on your patient. So if the seizure doesn't terminate with the induction of anesthesia, it's going to become clear pretty quickly. If you use an RSI dose of rocuronium, which is normally about 1 milligram per kilogram to 1.2 milligrams per kilogram, you can expect its effects to last 30 to 40 minutes. So if the seizure doesn't terminate with the bolus of thiopentone, it can be more difficult to tell if you've administered rocuronium. And if you have features such as persistent tachycardia, hypertension, or dilated pupils, it should make you very suspicious of ongoing seizure activity, which should be treated. And the effects of the seizure activity are just as damaging to the brain, whether you can see them or not. So the only problem with using succinylcholine for all cases of prolonged seizure is that it's often contraindicated. So the contraindications for using succinylcholine are hyperkalemia, and you have a patient who's just had a prolonged seizure with lots of muscle activity, so often their potassium is high, precluding succinylcholine's use. And it's also contraindicated in patients with prolonged immobility. And as many of the patients who present with prolonged seizures have developmental delay, this may contraindicate the use of succinylcholine in these patients. Other contraindications include severe muscle trauma, personal or family history of malignant hyperthermia, or burns greater than 10% body surface area. So what I would probably say is use succinylcholine where it's not contraindicated. If it is contraindicated, use rocuronium, but have a low threshold for administering a further bolus of thiopentone should there be concerns that there's ongoing seizure activity. If you're going to use succinylcholine, you may want to consider giving prophylactic atropine. The dose of this is 20 micrograms per kilogram, with a minimum dose of 100 micrograms and a maximum dose of 600 micrograms. It tends to be given more frequently in younger patients, but certainly you should have it drawn up for all intubations to use as rescue. And the final thing I want to say under airway is that I wouldn't routinely change the oral endotracheal tube for a nasal endotracheal tube, as we do with many other conditions. And the reason for this is that you would expect this patient's duration of intubation to be short. So when it comes to the ventilation, we would tend to use routine settings on the ventilator for patients intubated and ventilated for prolonged seizures. So a normal IT ratio of 1 to 2. For children under a year, we would use an I time of 0.6 to 0.8. 1 to 5 years, an I time of 0.8 to 1 second. Between 5 and 12 years, an I time of 1 to 1.2 seconds. And above 12 years, an I time of 1.2 to 1.5 seconds. And then we would adjust it depending on the blood gas. So for our child, I would use an I time of 0.8, an E time of 1.6, given a respiratory rate of 25 breaths per minute. So from a pressure point of view, a peak pressure around about sort of 20 centimetres of water, or a tidal volume of 68 mils per kilo is a reasonable starting point. And then again, would recommend adjusting that depending on your blood gas. And just standard PEEP should be fine, so around about sort of 5 centimetres of water is a good starting point. And again, adjust that depending on your oxygenation. So until raised intracranial pressure has been excluded, it's probably sensible to target a PaCO2 of 4.5 to 5 kilopascals and target a PaO2 of greater than 10 kilopascals. Once that's been excluded, you can relax that. And like any child you intubate and ventilate, a chest X-ray should be performed to confirm the endotracheal tube position. So looking at the circulation then, so it's important to ensure the patient has 2 working peripheral cannula. In general, a central arterial line aren't normally required unless the patient's hemodynamically unstable or there's concerns about raised intracranial pressure. I think a peripheral access is difficult. The external jugular vein is often easily accessible. Again, providing raised intracranial pressure isn't a concern. And you should be hereditary monitoring ECG and non-invasive blood pressure, and this should be continued. So we'll move on to the disability then. So if you're planning to extubate this child locally once they're awake enough, I wouldn't start any additional sedative agents unless the child is requiring transfer to CT. So although you can expect the effects of the thiopentone to wear off fairly quickly due to its redistribution, the sedating effects of the other anticonvulsants that will have been given and the postictal period often last longer. So it's often a little while before the patient's ready to extubate. So if you've used rocuronium for RSI, you often do need to administer a number of boluses of something short-acting like propofol until the effects of the rocuronium have worn off. If the facilities don't exist to safely extubate the child locally, then it would start routine sedation, so morphine of 10 to 60 mics per kilo per hour and midazolam 1 to 4 mics per kilo per minute. So one of the key points I really want to stress here is that you should try where possible to avoid further use of muscle relaxants, as this is going to interfere with your clinical neurological assessment. But if it's unavoidable and after trying sedation with boluses you still feel that you need to start a muscle relaxant, it's much better to do this by a bolus rather than an infusion. Another point, I wouldn't routinely tape the eyes closed provided they close normally, as you're going to be wanting to assess the pupils regularly as part of your ongoing CNS observations. It's also important to regularly monitor the blood sugar. Then we come on to whether we should or shouldn't perform a CT scan of the brain. And I think whether you do that depends on whether the seizure has any atypical features. Are there focal neurological signs? Is there signs of raised intracranial pressure? Or is there something worrying in the history? Or is the etiology of the seizure uncertain? And I think if that's the case, then you should perform a CT brain. But for example, if you have a patient with known epilepsy and numerous admissions for prolonged seizures, you may decide not to perform a CT scan if there was no worrying features on the history. So our patient from the initial case history has a very typical history of a prolonged febrile convulsion, which was generalized tonic-clonic, associated with a sudden spike in pyrexia, and has a strong family history of febrile convulsions and no abnormal or worrying features on her neurological exam. So my approach to her would be not to perform a CT scan initially, but should I have concerns with her neurology at any stage, or if she wasn't waking like I expected her to do after the RSI, then I would proceed to a CT scan at that stage. So if there's any concern at any stage about raised intracranial pressure, and things that would make you worry about that would be, for example, a relative bradycardia with hypertension, focal neurological signs, poorly reactive or unequal pupils, papilledema, or abnormal doll's eye reflexes. This should be treated immediately with 3 mL per kilo of 3% hypertonic saline over 15 minutes and starting neuroprotective measures. So I don't want to spend a lot of time on neuroprotective measures here because I'm planning to do a separate talk on raised ICP, but important things would be keeping the head up at 30 degrees and in the midline, Trying to avoid necklines. If the patient has a collar on, making sure it's not too tight, and making sure you don't set the PEEP too high. And all the above measures encourage venous drainage from the head. It's important that you control the amount of blood getting into the head by maintaining the CO2 between about 4.5 to 5 kilopascals and making sure your PaO2 is greater than 10. It's important that you meet the minimum cerebral perfusion target. Again, I'll cover this in the talk on raised ICP, and making sure your patient is normothermic and well sedated. Okay, so now I'm going to come on to sepsis. It's important to note that pyrexia itself can be the cause of a seizure. It's what we call a febrile convulsion, which tends to occur in children between 6 months of age and 6 years. The cause of pyrexia is often a simple viral illness, and the seizure tends to occur whenever there's a sudden rise in pyrexia. And it's this sudden rise in temperature's effect on the developing brain that causes the febrile convulsion. It's also important to note that a seizure, and particularly a prolonged seizure, can cause pyrexia in a child even in the absence of infection. And it's the increased muscle activity and cerebral activity that causes that pyrexia. So interpreting pyrexia in the setting of a prolonged seizure is difficult. And I think if there's any suspicion at all that this could be a meningitis or encephalitis, or that the cause of the pyrexia is unknown, then a safe approach would be to administer intravenous antibiotics and acyclovir until further information becomes available. And from an antibiotic point of view for community-acquired infection, intravenous cefotaxime, 50 milligrams per kilogram, is appropriate for most patients. And if you have a child that's 3 months or less, you should add in some amoxicillin to cover Listeria meningitis. The acyclovir dosing varies depending on the child's age, but the common mistake I see is that people don't use the high dose, the encephalitis dose. And I think if you're going to be administering acyclovir in this scenario, it's to cover encephalitis, so make sure you use the right dose. So provided it doesn't delay the administration of the antimicrobials, a blood culture should be taken prior to their administration where possible. However, a lumbar puncture is contraindicated in the postictal phase and must not be performed. So I just want to stress here that a normal CT scan does not rule out increased intracranial pressure. And even if you suspect this child does have a meningitis or an encephalitis, you should not perform a lumbar puncture at this stage. It can be done at a later stage when raised intracranial pressure can be excluded by clinical examination in the intensive care environment. So I've already mentioned that in children between 6 months and 6 years of age, a high temperature itself can cause a seizure, and that if the child is having ongoing temperatures, are obviously at risk of having a further seizure, so temperature should be controlled. So there's a number of methods to do this, and using antipyretics such as paracetamol or ibuprofen is probably one of the most effective ways. The ibuprofen can only be given intrally, so once you've got the nasogastric tube in, you can give it that way. Whereas paracetamol, although can also be given via the nasogastric tube, can also be given rectally or intravenously, so it can be given prior to getting that nasogastric tube in. If the patient's warm, they should be exposed by removing blankets and unnecessary clothing, and a cooler fan can be used to help lower the temperature. If the above measures are ineffective and the temperature is continuing to rise and there's concerns that it will trigger a further seizure, you can try more active cooling measures such as placing ice packs over the axilla and the groin. We're going to come on to renal now, so you're going to be putting all these patients up on maintenance fluids for transfer to intensive care or while they're nil by mouth following the intubation and possible extubation period. So like all intensive care patients, they're at risk of SIADH, so intravenous fluid should be restricted. I use 80% of maintenance as a standard, and you should use isotonic fluids, so normal saline with 5% dextrose, plus or minus added potassium, depending on the serum potassium level. We don't normally need to catheterize the bladder in children who are intubated and ventilated for status epilepticus, as they tend to extubate relatively quickly. However, if there's concerns regarding sepsis or pyrexia with no obvious source, it's often a good opportunity while the patient's asleep to perform an in-out catheter specimen of urine. So moving on to gastrointestinal, it's important to insert a nasogastric tube or orogastric tube if there's any history of trauma. This should then be aspirated to remove any swallowed air that may be spent in the diaphragm, and then leave it on free drainage. So looking at the labs and electrolytes, in all patients with a prolonged seizure, I would routinely check a full blood picture, urea electrolytes, liver function tests, calcium, magnesium, phosphate, CRP, and send off a blood gas with a lactate on it. If I'm going to start antibiotics because of concerns regarding sepsis, I would also check a blood culture. And if the patient's on regular anticonvulsants, it'd be worth sending off some levels to see if those levels are therapeutic. So if the cause of the seizure is unknown, it would also be worth sending off a metabolic screen, including ammonia, and sending off a toxicology screen as well, in addition to the above investigations. If the above investigations show hyponatremia, which could be responsible for the seizures, the recommended treatment is 4 ml per kilo of 3% hypertonic saline over 15 minutes. And this is normally enough to terminate the seizure if this is the cause. And if there's any signs of hypoglycemia, it should be treated in the standard way with 2 ml per kilo of 10% dextrose. So now I want to move on to the drugs and infusions that are used for the treatment of prolonged seizures, and to cover them in a little bit more detail. So the first drug I want to look at is lorazepam. So studies have shown that intravenous lorazepam is more effective than both rectal diazepam and buccalmidazolam, and that it also has a lower risk of respiratory depression and a longer duration of use than both these other drugs. So where possible, it should be used first line for the treatment of status epilepticus. But that's provided intravenous access can be rapidly established. If it can't, then you should use one of the other drugs. So the normal dose is 0.1 milligrams per kilogram, up to a maximum of 4 milligrams. And this dose can be repeated after 10 minutes if the seizure is still ongoing, provided no more than 2 doses of any benzodiazepine are given. And it's important that you include the pre-hospital medications when making that assessment. So the reason for not giving any more than 2 doses of benzodiazepines are that the benzodiazepines work best early in status epilepticus, and studies have shown that the further status epilepticus goes on, the less likely benzodiazepines are to work. So by administering a 3rd dose of benzodiazepines, it's unlikely to work, and all you really will be doing is delaying the administration of another medicine, which is more likely to work. As well as this, the risk of respiratory depression increases significantly if more than 2 doses of benzodiazepines are given, so it should not be done. When you look at the APLS algorithm for status epilepticus, they recommend that the first dose of benzodiazepines should be intravenous lorazepam, provided that intravenous access can be rapidly established, and if not, you should use either buccalmidazolam or rectal diazepam. However, looking at the algorithm, you can see that the 2nd dose of benzodiazepines for in-hospital administration should be lorazepam, and that should be either via an intravenous line or an intraosseous line. So it's important that if intravenous access can't be rapidly established, go on ahead and give an alternative treatment, but by the time it gets to 10 minutes, you should have either intravenous or intraosseous access so that lorazepam can be used for your second dose of benzodiazepines. And also you're going to need that intravenous or intraosseous access to administer the other medications that are required. When using any benzodiazepine, it's important that you monitor respiration, as respiratory depression is a risk, and be prepared to support the respiration with bag and valve mask should respiratory depression occur. So now I want to look at buccalmidazolam. So studies have shown that buccalmidazolam is more effective than rectal diazepam, so it should be used first line when intravenous access cannot be rapidly established. And the risk of respiratory depression between buccalmidazolam and rectal diazepam is the same. So the dose is 0.5 milligrams per kilogram administered buccally, up to a maximum dose of 10 milligrams. So now I want to go on to diazepam. So as we've already said, both intravenous lorazepam and buccalmidazolam are more effective. So rectal diazepam should really be reserved for cases where intravenous access can't be rapidly established, and buccalmidazolam is either unavailable or contraindicated. I'm going to cover the dosing anyway, so the dose is 0.5 milligrams per kilogram rectally, up to a maximum dose of 10 milligrams. So should intravenous access be available, however, lorazepam is unavailable, intravenous diazepam can be administered instead in a dose of 0.25 milligrams per kilogram, up to a maximum dose of 10 milligrams. This can also be given via intraosseous injection. And one important note when using diazepam is that you should, where possible, use the diazepam emulsion, i.e. the diazomules, as this preparation is least irritant to the veins. So I'm going to go on to phenytoin. So phenytoin is indicated if the seizure hasn't been terminated after 2 doses of benzodiazepines. So phenytoin should be administered in a dose of 20 milligrams per kilogram, up to a maximum dose of 1.5 grams by intravenous infusion over 20 minutes via a 0.25 to 0.5 micron filter with ECG and blood pressure monitoring. If the patient's already on maintenance phenytoin, phenobarbital should be used instead, and I'm going to cover the dosing of phenobarbital shortly. The only situation where it is okay to go on ahead and administer more phenytoin is if you know that the plasma phenytoin level is less than 5 milligrams per litre. So another important point that I want to stress is that phenytoin should be avoided in cardiovascularly unstable patients, and in this scenario I would use phenobarbital instead. You can consider checking a plasma level 1 to 2 hours after completion of the loading dose of phenytoin, and the normal therapeutic range is 6 to 15 milligrams per litre for those under 3 months of age, and for those 3 months of age and greater, the normal therapeutic range is 10 to 20 milligrams per litre. So this isn't something that I would routinely do in all patients, as most of the time you give a phenytoin loading dose and don't give any more because the seizure is terminated and there's no further recurrence. So I'd probably reserve phenytoin levels for patients who have recurrent seizures following phenytoin loading dose, or where I'm planning to start maintenance phenytoin. So as preparation of the phenytoin infusion takes time, it's good practice to start preparing this immediately after administering the second dose of benzodiazepines, so that if the seizure doesn't terminate 10 minutes after the second dose of benzodiazepines, you're ready to go with the phenytoin infusion without any delay. And I would actually have the infusion in the infusion pump with the rate set and connected up to the patient, so that I'm ready to just hit the go button once 10 minutes have passed following the second dose of benzodiazepines. So now I want to go on to phenobarbital. So it's mainly used where the patient is on maintenance phenytoin, or where phenytoin is contraindicated. It's the same dose as you would give phenytoin, 20 milligrams per kilogram, and is given by intravenous infusion over 20 minutes, up to a maximum dose of 1 gram. It's also recommended that you can consider checking the plasma levels 2 to 3 hours following completion of the loading dose to confirm that you've got the level up into the therapeutic range, which is 15 to 40 milligrams per litre. So now I want to cover paraldehyde. So up until 2011, paraldehyde was in the APLS algorithm. They decided to remove this from the algorithm, but not from the guidelines, and that is because there's very little evidence that paraldehyde actually works, and there is quite good evidence that earlier administration of phenytoin is more likely to be effective. So the old algorithm was that you would give the paraldehyde after the second dose of benzodiazepines and wait an additional 10 minutes before starting the phenytoin. So in removing it from the algorithm, you got the phenytoin in that bit earlier. So what's currently recommended is that at the same time as phenytoin, you have the option to give paraldehyde, but its administration shouldn't delay the administration of the phenytoin. So you should make your phenytoin up first, and then if you want to, you can make up some paraldehyde and give it. If you do want to give it, the dose is 0.8 mils per kilo of a 50% paraldehyde, 50% olive oil, pre-mixed enema, up to a maximum dose of 20 mils. So contrary to what the evidence says, I personally have found paraldehyde to be quite effective, so I do give it at the same time as the phenytoin, but it's really up to yourself whether you do or don't want to give it. So now I want to come on to refractory seizures or recurrent seizures following induction of anesthesia and the treatment options that you have for these. So this is much rarer than the prolonged seizure which settles with induction of anesthesia. And the first thing that I would advise if you think this is what's going on would be to discuss this with the retrieval team, who will likely conference in a paediatric neurologist onto the call, and a decision about further management will be made. So it would be important to check that you've identified and treated any electrolyte abnormalities. If you haven't already looked for toxin ingestion or metabolic problems, these investigations should be sent off. And again, if a CT scan of the brain hasn't been performed, it's probably worth doing this now. Another thing to think about is pyridoxine-dependent seizures, and the current guidance is this should be considered in all children under 2 years of age with refractory status epilepticus with no obvious cause, although these commonly present in the neonatal period. So after a discussion with a paediatric neurologist, if the decision is made to try a trial of pyridoxine, the normal dose is 100 milligrams, given by slow intravenous injection over 3 to 5 minutes. So now I want to come on to the 3 main treatment options for refractory status epilepticus, which are midazolam infusion, thiopentone infusion, and high-dose phenobarbital. So I'm going to start with midazolam infusion because I think this is probably the option you're going to be most likely asked to start. So you start off with an intravenous bolus of 0.5 milligrams per kilogram up to a maximum dose of 10 milligrams of midazolam, and then start a continuous infusion of 4 mics per kilo per minute, which is the upper end of the sedation dose. You should continue to monitor for seizure activity, and if after 5 minutes there's ongoing seizure activity, you repeat the bolus and increase the rate of the infusion by 4 mics per kilo per minute, up to 8 mics per kilo per minute. And you continue this sequence every 5 minutes. Give it a 0.5 milligrams per kilogram bolus and increasing the rate of the infusion by 4 mics per kilo per minute until either the seizure is controlled or a maximum dose of 32 mics per kilo per minute is reached. So obviously with using such high doses of benzodiazepines, you should expect cardiovascular instability and be prepared to support the cardiovascular system. So if the seizures aren't controlled by the time you reach 32 mics per kilo per minute, you should stop the midazolam and start a thiopentone infusion. So I'm going to cover the thiopentone now. So you tend to start this off with a standard loading dose, which is 4 milligrams per kilogram or 2 milligrams per kilogram in a neonate, and then start an infusion at 2 milligrams per kilogram per hour. Obviously, all the doses I've mentioned will need to be reduced if you have a hemodynamically unstable patient. The thiopentone infusion should then be titrated to seizure control, which ideally should be assessed as burst suppression using either EEG or CFAM. The maximum dose you can use of thiopentone is 10 milligrams per kilogram per hour. With thiopentone infusion, you should expect hypotension, and a central line should be sighted. And if any hypotension occurs, it's likely to be due to vasodilatation, so noradrenaline would be the ideal drug to treat any hypotension. So the third treatment option I want to mention for refractory status epilepticus would be high-dose phenobarbital. So with this, after administration of a normal loading dose, you just continue to repeat half-loading doses of phenobarbital, 10 milligrams per kilogram, every 30 minutes until seizure is controlled, or up to a maximum of 120 milligrams per kilogram per day. So the studies that look at refractory status epilepticus in children using high-dose phenobarbital showed serum levels as high as 343 milligrams per litre required to achieve seizure control. And most of the children did seem to tolerate this well from a cardiovascular point of view, but most children did require intubation and ventilation for respiratory depression. So finally, I just want to mention some of the other treatments for refractory status epilepticus. So when starting one of the other three treatments that I've mentioned, often the neurologist will want you to add in an additional anticonvulsant. And both levetiracetam and sodium valproate are made available in intravenous preparations, which can be added in, or topiramate can be given by the nasogastric tube. There's some evidence that ketamine may be helpful for the late treatment of refractory status epilepticus. Likewise, isoflurane has been shown to induce burst suppression in refractory status epilepticus. However, there was a high rate of seizure recurrence once the isoflurane was discontinued. It's also important to note that all the patients in the studies needed vasopressor support for hypotension. So not all the volatile anesthetic agents share this property, and in fact sevoflurane can cause epileptiform discharges. The final treatment I want to mention is propofol infusion, which has been used with some success in adults. However, due to the risk of propofol infusion syndrome in children, this isn't a therapy that can be recommended. So I hope you found that useful. Please get in contact if you do have any comments or questions, and I'd recommend you have a look at the accompanying book chapter, to which I'll put a link to in the show notes. I'm probably going to try and get another podcast out in the next few weeks. So if you subscribe either at YouTube or through your podcast browser, you'll get automatic notification of when that podcast is released. Thanks for listening.